Okay. So let's, first of all, I thank you for the invitation. I'm really very pleased to meet here. My English is not so perfect, but I will try to do my best. And what I'm going to do today, I'm a neurologist. Since 1991, I follow patients with the neuromuscular disorders. I did long trips during my life. I worked with the people such Michel Fardot in Paris or John Bach in the United States, and abroad in Italy, all the experience that they had following the patients. In the last 30 years, I've been following hundreds of Duchenne patients. And actually, I'm the head of neuromuscular unit. And I didn't make a right count, but probably I'm following more than 100 Duchenne at the moment. What I'm going to do is just today to show how to follow Duchenne, or at least how I follow a Duchenne. Because many times, you know, also amongst us, amongst the specialists, the way to follow Duchenne may be a little bit different. Someone may have different ideas. But what I always say that is the oldest Duchenne teach us the mistakes and teach us what we should not do when we see, for example, the patients that actually have 30 years old or 40 years old. And this, from them, we start to make a better life for them. Now, first of all, I would like to say that a Duchenne patient doesn't need a quantity of life. We should work a lot of quality of life. Because many times, you know, we think that to let the Duchenne patient live 30 years, 40 years is the only target. But I think, and these, I can tell these things because, you know, I speak with Duchenne patients every day. They really want to have also a good quality of life. And we have to work a lot on this topic and not only on the quantity. Now, we know very well that if you have to follow a patient with Duchenne, you need a lot of specialties. And you should do an approach that is a team approach. But unfortunately, at least this is my experience, it's not easy to put together all these doctors, all these specialists. And a neurologist, or at least someone that want to follow patients with neuromuscular disease, should have a multidisciplinary knowledge. So for this reason, I have been studying pulmonology, cardiology, neurology, physiatry. So I put in my head a lot of specialties. And then I ask to my colleagues many times some opinion, but it's very important that the supervision who follow Duchenne patients as himself, as a neurologist, the knowledge of many branches of the medicine. I will show now 1, 2, 3 books. These have made the story of Duchenne. We see this book, books that, you know, we read 20 years ago. This is from Frank Mastaglia, but then we have one from Alan Emery. Then we have also from Victor Dubowitz. They made the history of the neuromuscular disease. But when you read these books, then you see always that Duchenne was dying when he was 20, probably a little bit more than 20. So they were very depressive books because actually this never happened anymore. It's practically impossible that Duchenne patients can live less than 20 years. I don't remember a case in my life in the last 20 years. In effect, this is Paolo. Paolo is 53 years old, and he has Duchenne. I publish this case because he's the oldest Duchenne in the world. But just to let you to show that there are Duchenne that can live also very long life. Unfortunately, Paolo died 2 years ago. Probably he was one of the first COVID patients, and he was not in Bologna, he was in his house, but unfortunately I lost Paolo 2 years ago, but he lived until 54 years old. So this means that Duchenne patients can live very long. It depends always by the treatment, and many times also by the heart, because the lucky of Paolo was to have, he had a very good heart, and the dystrophy probably was in his heart. For the rest, he had a very, very severe disease. Now, we know very well the 3 phases of Duchenne. I think I'm not teaching my colleagues that generally, when we speak about the natural history of Duchenne, we have to divide their life in 3 phases. The initial phases, generally between 0 and 6, and I call the diagnosis phases, in which generally we make a diagnosis. You see sign very typical, the calf hypertrophy, but many times, you know, the pediatrician doesn't make any diagnosis because, you know, the boy looks normal. And many times the boy looks also with very good muscles. And most of the time, the diagnosis is made by the mother. And the mother, because I see the difference between, for example, is a child from other children that they have. And they say to the doctor, you see, for me, my son has some problems. Many times, also the pediatrician can make a diagnosis. They say, okay, it's okay, don't worry. You will see that he will improve, it's just a period. Then they make a blood examination and they discover to have the Duchenne. Most of the time, the diagnosis between 0 and 3 and 0, 4 years old happen with casualties, because, you know, you make an examination for other things, you find a very high CK. Then we have the transition phase, in which Duchenne patients, these are old pictures, you know, but just to say the phenotype, you see the hyperlordosis, you see the retraction, you see the Achilles tendons that start to retract. So there is a phase in which our target, I will show you, will be to prolong as maximum as we can their deambulation, because it's very important that Duchenne patients walk as much as possible. And then we have the 3rd phase that is not ambulatory phase, in which we have to think about other things, for example, scoliosis, the heart, and the ventilation, and the autonomy thanks to medical device and other things. So generally it starts when they are 12, but sometimes can be 13, sometimes can be 11. It depends by boy to boy. It depends also by the history of the boy until that age. So what should we do? And this generally in these phases, generally in the initial phase, we have to work with physiotherapy. First of all, you have always to think that these are kids, and the kids, they have to live as kids. So otherwise they will become more sick than they are. Generally, I let them to live as normal as they can, but what I suggest to families just to start a bit of physiotherapy, just to let the child know what is the physiotherapy. And then we start to use orthosis, but then I will come back later on this topic. Then in the intermediate phase, our principal target is to prolong walking. So we have to work to prolong walking, and I will show what we do to prolong walking. But we will speak about drug treatment principally, and we will speak about steroids. Then we have a non-ambulatory phase in which the boy, unfortunately, lost his walk, his autonomous walking. And we have to think about then other very important things. It starts the most difficult part of their life, in which you have to look very careful to the scoliosis, to the heart, to the respiratory treatment. So we have to put our attention on other things. Unfortunately, today I have not time to speak about everything, but I thought to speak you about the ventilatory problems and also scoliosis. Then if someone wants to make questions about heart disease or other things, is completely free to do it at the end of the communication. So the objective that we have to follow, of course, it depends by the natural history. Now we know very well the natural history of Duchenne. Probably is the only disease, neuromuscular disease, in which we know very well the natural history. So we cannot make mistake because, you know, when you know very well the natural history, you know what will going to happen. And in that case, you have to prevent and not to arrive late when already the problem is there and you cannot do anything. For example, these are very terrible things. These are, I call unnecessary complication. I cannot see anymore people arriving in Bologna with such scoliosis and such position of a boy that arrived in Bologna with such wheelchair, sitting in that position. Then we tried to work on him, and this was his wheelchair. Later on, we did our job. Of boys that when they are already 6 or 7, they arrive with very bad retraction of the Achilles tendon, and they walk just because there is the hand of their mother. But it's not possible in 2023 to see kids like this arriving when they are 6, 7 with such feet. These are also very bad feet. Feet of boy that has 9 years old. You see the feet are completely, the retraction is completely of the Achilles tendon. You have a complete equinus of the feet. So which are the targets that we have to take in consideration when we follow Duchenne patients? First of all, we have to preserve maximum autonomy for as long as possible. Then we have to try to counteract the aggravation of clinical sign. So we know which are the clinical signs. We know what will happen a boy that in front of me as a 3 years old, but when I see a patient with a 3 years old, I already imagine him when he will be 20. So for this reason, I have to try to avoid everything that is possible to avoid. We don't need, these boys, they don't need unnecessary complications. And if we follow them very well, they will not have unnecessary complications because at the end, their life can be much worse if we make mistake. Then we have to try to work on the compensation, and we have to try to delay as possible as we can the worsening evolution of the disease. So for this reason, you need a deep knowledge. You cannot invent a specialist in Duchenne. So if you have an experience in Duchenne, just be humble and say, you know, I never seen Duchenne, or probably I have seen only 2 Duchenne, and go someone else. So you cannot follow Duchenne patients if you have not a deep knowledge. And you can try to work on it. So you can study, you can enter in contact with other colleagues that have experience with Duchenne. But you cannot think also as a neurologist to follow Duchenne patients if you never know or you have never seen a Duchenne patient. And sometimes today happen that someone become expert in Duchenne also if has never seen one of those, or probably has seen 1 or 2 of those. You really, my experience taught me that you need a lot of years to become a specialist in such kind of complex diseases. So let's speak now about what we do to prolong independent walking. And we have to start by the physiology, because if we know the physiology of the walking, then we can understand how to help a boy with Duchenne to try to walk independently long time. Which are the factors that probably, but this is happen also for us, that let us to have problems to walk: pain, strength, contractures, equilibrium, spinal deformity, muscle fatigue. So all these things can make the walking of boy of Duchenne, but I would like to say also in a normal boy without any disease, a problematic. So when you walk, you want to walk in a good way, you need a good stability. The feet are very important. If you don't work on the feet of Duchenne, then you will have problems to walk. And many times Duchenne stop walking not because they are weak, but because the feet are so terrible that they cannot more walk anymore. They have bad problems with the equilibrium. And many times they can stop walking when they are 7, just because, you know, no one thought about their feet. And of course, you need a good muscular strength to have a normal gait. In Duchenne, what happens? So we know very well that there are muscles in Duchenne that are weaker and muscles in Duchenne that are stronger. And for this reason, you have you can have contractors, and in Duchenne you have those because, you know, all the flexors are stronger than the extensors. For example, the weakness of the hip extensors, then you can, will try to develop hip flexors retractions. The knee extensors are weak, and for this reason, the knee flexors are stronger, and this will generally produce muscle retraction to the knee flexors. And so also on the foot, the dorsiflexors of the foot are very weak, or at least are weaker than the plantar flexors. So we know very well which are the muscles are weaker, and for this reason, we have to be very careful. We have to try to limit the muscle retraction working on this physiological data that we have when we see a patient with Duchenne. So, and for this reason, for example, the weakness of the hip extensor, what does? Practically forward the center of the body. And for this reason, they develop hyperlordosis. And also, when you have a very weak quadriceps, then you will walk on the tools. But, you know, this makes the walking very unbalanced. And sometimes, you know, a Duchenne boy is normal that he walks on the tools, but it's very important that the ankle does not retract, the Achilles tendon does not retract. So we have to be really very careful to try to avoid retraction that then will make very important problems for these boys to walk, or anyway to have a good normal gait with good equilibrium. And so for example, weakness in dorsiflexion of the foot will facilitate retraction of the Achilles tendon. So, and the role of the physiotherapy, the targets is just to try to prevent damage and to try to slow down the decline of muscle strength and maintain autonomy. So the physiotherapy play this role. We have to try with the physiotherapy and also using orthosis, you will see, to try to prevent, or at least to let the damage much less worse than could be if you didn't do anything. At the end, when the boy is a little bit older, then you have to work also on the respiratory treatment. So you have to choose very carefully orthosis, and you have also to choose very carefully wheelchair, and because these will play a very important role in the life of these boys. Very important at the end is also the family training. The family, I think, is the best nurse for these boys. And for example, especially when they get older, I see mothers that know more than intensivist or more than pulmonologist, because, you know, we teach family to use ventilators, cuff assist, aspirators. So sometimes mothers with only very low school diploma, they are really incredibly clever nurses, but they work on their child better than they could do in intensive care unit. So we train a lot of family. We try to explain the family what they have to do to try to avoid as much as they can damage to their children. Because, you know, in Duchenne, you have this very bad vicious circle, and you have to work on one of these. You see, muscle weakness can make imbalance, and then the imbalance can create deformity, and then you can have rigid contractures and compensation. So, you know, we have to try to just avoid this vicious circle. And today we can, because when you know the natural history and you know what to do, then generally you can avoid this, you can break this circle. You see, for example, in the transitional phases, said before, the hip flexors are stronger than the hip extensor. So then you can develop contractures on the hip flexors. And the same on the dorsiflexor, the foot, because, you know, the ankle dorsiflexor is weaker than the plantar. And then you can have, for example, contractures of the Achilles tendon. And if you are not very careful to this clinical important sign, then you will have a bad feet, because, you know, if you don't take care about the foot of your Duchenne patients, then you will develop very bad contractures, and as I said before, he can stop much earlier to walk than he could do. For this reason, you know, these are examples, but for example, is a boy arrived at 6 years old with already 35 degree of retraction of the Achilles tendon. Generally, you have to do the sum between 90 and 33. So in this case, is 125. This ankle. But when a boy is 6 years old, the foot should be like this, you need 90 degrees. This is good foot. So you have to try as much as you can to try to keep the foot of the Duchenne boy at 90 degrees. In that case, he will not have much problems to walk. What we do, of course, we use orthosis. Now, you know, when you listen other scientists in the world, many times they say, you know, the Duchenne patient doesn't need of orthosis. But my experience, that is almost 30 years of experience, tell me that these orthoses are very important. I've seen if you put these orthoses, we generally start when the boy is 3 years of age. It's very important because, you know, if you think that with only the physiotherapy, you could delay the retraction of the Achilles tendon, I think it is not possible, because you should need 6 hours a day of physiotherapy to do the work that does an orthosis. Of course, what is very important is that the child should not be obliged to put orthosis, and you have to be very careful. You have to have a lot of patience, and what I do is just make them colored, or say to the parents, when you know, tell your child to put only one in one night, the other one the other night. So the child has to go near this orthosis slowly. Never be obliged to be aggressive with children, because this is not good. So we put orthosis, and I think this is a very good help. And orthosis, they are very light. Sometimes you use polyethylene, but 2 millimeters of sides, and they are really very, very light. Because our goal is to arrive at 10 years of age with such feet, and not with feet like this. This is our goal, because, you know, also if a Duchenne patient stop walking, if he has good feet, then he can also stand, also with standing, you will see later. But if he has feet like this, he will not stand, because it's impossible. It's impossible. He will sit. But if he sits in a wheelchair when he is 10 or probably 9, then he will develop very bad scoliosis, as many times happen. So more these kids are in upright position, then less scoliosis they will have. So it's okay. This is okay. As I said before, it's very important to act on the progression of the detection, but I already explained this point. Now we have also surgery. So in some cases, when probably you cannot do anything, or probably the boy arrived too late, in those cases we use surgery. And you see, with mean invasive surgery is a subepidermal tenotomy. So there are orthopedics colleagues that are very clever. They don't do open surgery. They do just really mean invasive surgery. One foot like this can become again like what we want. So 90 degrees. You see it before and after. See this and this. So we use also, as we see, a medical device just to prolong the upright position. In the past, we use these orthoses, but we don't use anymore since I'm at least in my unit 15 years, because these orthoses generally, first of all, they are very dangerous, because if the boy fall, it's terrible, because, you know, they are blocked, and when they fall with such orthosis, they can have a very bad trauma. And also because with these orthoses, they try also to walk, but when they walk, they stress a lot of the heart, because, you know, it's not easy to walk with this such orthosis. Then these orthoses are the history. Now we don't use anymore such thing. We use this standing. They can stand upright very, very well. And we also have a wheelchair with that can put the boys in an upright position. But for example, many times they use such kind of this is an easy stand. We use the easy stand. We can change the positions. So they are very, very good to let them to stay also an hour, 2 hours a day in upright position. Now, another thing that we use to try to prolong the walking, but anyway, to delay the disease, is the steroids. Today, we have also other therapy that we call innovative therapy. But unfortunately, actually, until now, no one in the world has left steroids. So if you see all the trials, they use innovative drugs, but the boys never stop steroids. So it means that the steroids that are very, very old drugs, we know very well how they work. We know very well the side effects, are actually the only drugs that improve with certainly the clinical findings of these boys. And the steroids, what does it do? Generally, you know, increase muscle endurance, slow down the progression of the Duchenne, and also increase muscle strength. And when we visit the patients, we do all these tests. We do functional tests, we do myometry, we do manual muscle testing. So we know very well, and we are sure that the steroids do such a job. Generally, we start at when the boy is 3-4 years. It depends. Sometimes we start at 4 years when there is a delay of the mental situation. If there is a cognitive impairment, we try to start a little bit later, because, you know, sometimes you know, the boy doesn't tell you if he has some side effects, or anyway. You cannot try to, or it becomes very difficult to try to understand if the steroids are working or not, because you cannot test very well Duchenne boy with important cognitive impairment. And we have a different administration scheme. For example, you can give steroids every day, every other day, 10 days yes, 10 days no, high dosage. So we have a different scheme. Generally, I start always with the schema that gives very few side effects. For example, 10 days yes, 10 days no. Then I see how it's following. For example, I have a Duchenne that actually are 12 years old that are taking steroids 10 days yes, 10 days no since 9 years. And they go very well. So it's not always, we are not always obliged to give steroids every day. We have to follow, see the results, and if the results does not convince us, then in that case, we can change the schema. At least this is what I do in Bologna. And what are the side effects of the steroids? We know also this very well. You can have hypertension, so you need to ask the pediatrician to check the blood pressure at least one times every month. Then there is a problem of the osteoporosis, but actually, if you give vitamin D and calcium, generally they have never bad osteoporosis, at least when they get older. But you know, osteoporosis is always present in Duchenne patients because it depends by the fact that they move less than a normal boy, and this clearly is a point that may favorite osteoporosis. Then, you know, steroids can give growth delay and low stature, especially when you give a lot of steroids. I've seen boys arrived with a very bad low stature, but fat, because they were taking steroids every day, but without checking or anyway without thinking about also these things, because you know we think always to try to let them to walk, but of course other factors are very important. Also the phenotype is very important, because these boys, when they see themselves on the mirror, they like they want to see in front of them a normal child, or at least as normal as possible. And sometimes you have, you know, boys 12 years old that are very with a very low stature. Then obesity, you have to be very careful to the diet, to the nutrition, and irritability. So for this reason, we always say the parents, you know, if you see your child getting very angry many times, then can be steroids. And also, not all children respond to therapy. Very few children with Duchenne, they did not respond to steroids. So generally they respond, but I have really very rare Duchenne patients that did not respond to steroids therapy. So what we do, generally, these are the examination. You should make the densitometry, vitamin D, calcium. Then we use also biphosphonate when, for example, I start when they are already 10. And then you should just check the weight very carefully. You have to speak with the parental. So the who follow Duchenne should be sure that the therapy doesn't give a lot of side effects, probably less good effects. Now we stop about, we have seen what we do generally in the initial phase, what we do to prolong their walking. Of course, we have not much time to speak about everything, but today I also I thought to speak about ventilation because I think it's very important. And also in this case, you should need 2 hours, 3 hours at least to speak all the things about ventilation. But I will try to speak about few points, very important points. First of all, this is Italian, but anyway, we breathe with the muscles. So it's very important to understand that we have inspiratory muscles and expiratory muscles. And generally, in Duchenne patients, the expiratory muscles are the muscles that get weaker earlier. And for this reason, sometimes you can have problems with cough, and you can have a bronchopneumonia before someone understands that there are respiratory problems. This is generally, well, I would like to say in all neuromuscular disorders. So you can have a hypoventilation because the muscles become weaker. You can have inability to cough because when you have respiratory muscles weak, you are no more much strength to cough. And also the scoliosis can worsen the situation. For example, okay. So when we see a patient with Duchenne, but we can speak about neuromuscular disorders because when we speak about ventilation, all neuromuscular disorders probably are the same. You have an initial phase in which you have normal functions. Then you have a second phase in which the boys, they breathe normally, but they have ineffective cough, and we have to be very careful for that. Then we have a third phase in which during the day they breathe very well, but during the night the problems become there because the ventilation is inadequate. And then we start nasal ventilation, for example. And then when the Duchenne patients can breathe in an adequately way during the night and during the day. To monitor the respiratory function, you should do, and I'm just telling this to the colleagues, but the spirometry is very important. It's very important to do spirometry in a sitting position and supine. Then you have to check the peak of flow. That is another test that is very important because we can understand whether a boy with Duchenne can have problems if he gets some cold or worse pneumonia. Then you have to do generally enough nocturnal oximetry to check whether during the night they have a desaturation. And we use also capnography. Generally, we don't, well, I use also hemogas analysis, but it's more invasive. Generally, also the capnography is very good, at least when they don't do 24 hours ventilation. So you can check the CO2 with a non-invasive way. When it's necessary, we do hemogas analysis. And this is for families. What should you do to avoid risk? First of all, you don't wait that the respiratory failure is too bad. So if you have to go to the hospital with a ventilatory problem, you have to go immediately. So don't wait. And today we give to the family saturimeter, and the families can understand if eventually the desaturation is very bad or is not so bad. And in that case, you can wait. If you are not able at home to treat your child, or anyway, you see that things start to become dangerous, then go to the hospital. Don't arrive too late, because if that hospital has no experience, if your child arrives in that hospital in a good way, then we'll try to treat him. But if the child is in a bad situation, and you go in a hospital and they don't know anything about how to treat a Duchenne patient, then the child will get the worst things in the hospital. So, of course, you have to try to avoid as much as you can intensive care unit, because when you arrive there, then everything becomes difficult. You need really a lot of experience to extubate a patient with Duchenne. Another thing very important is to have a specialist near your house. This is a dream of all families, to have a specialist near their house that understand very well. And it's very good that in Ukraine also there are colleagues actually that are specialists in neuromuscular disorders. They can also treat ventilatory problems. So this is what John Bach has taught me in the United States, but this is very important, and I tell this This is for colleagues. So you see, when you have a respiratory problem, you have a desaturation, so the PO2, the oxygen goes down. But when you have a ventilatory problems, in that case, you have to be very careful to the CO2. So because your problem will be that the carbon dioxide will go up. And the mistake that many times is made is that when you arrive with a boy with Duchenne to the emergency room, and he is desaturating, so for example, he has 80 of oxygen, the first thing that they do many times is just give oxygen, but they don't treat the cough inability. They don't treat the mucus. So in that case, the oxygen improve the saturation, but unfortunately it doesn't improve the mucus that grows. So the CO2 grow, and these boys, they will need of 1 liter, and then 2 liters, 3 liters, 4 liters of oxygen, and then they go in coma, hypercapnic coma. And in those cases, the best thing that they do is just to intubate these patients. But this is really a mistake, because if you know Duchenne, or anyway, if you have experienced neuromuscular disorders, you give oxygen, but you treat also the cough inability. You use the cough assist machine also in emergency room. And this is explained why the oxygen many times is poisoning the Duchenne patients, is not helping. So it's not bad to give oxygen, but don't forget never that Duchenne has difficulty in coughing. So you have to know how to clear the airway. This is the peak outflow. It's very important, the test. So if you have a peak outflow less than 270 liters a minute, then you need to teach the families the cough assist. And when you do the follow-up of Duchenne every 6 months or every year, it depends by the age, this test should be always done. And when it's less than 270, you need to teach how to use a cough assist. You cannot wait, because in that case, you know, the boy is well, he can cough. And many times the families say, you know, my boy has never problems, he never take influenza. Don't care about it. If he has a peak outflow less than 270, teach the family to use a cough assist, teach the boy to use cough assist machine. What we do training. You see, these are mothers and that teach to use ambu bags, cough assist. And the best thing to do is just to educate the families to treat these things, because, you know, the families is the first emergency room that a boy has. And if they know how to do it, I can tell you, and for sure, that you don't need most of the time to go to the hospital. You treat your boy at home. So this is a slide just to say when we start nasal ventilation, and generally we start nasal ventilation when the PaCO2 is more than 45 during the day, or you have symptoms of hypoventilation during the night when you do nocturnal oximetry. For example, you have to be very careful, because sometimes they need the ventilation when the spirometry show the forced vital capacity less than 50%, or they have less than 15 milliliters kilograms of air in their lungs. Or if they do many times, for example, they have problems with the bronchopneumonia, so you have to think also about to start nasal ventilation. And if you use those in a good way, you will see that you will have in your country, but everywhere, less morbidity and mortality. You will have less days of hospitalization of these boys, because if a hospital knows very well how to treat them, you don't need to stay 1 month in an intensive care unit. You can stay just a few days in normal medicine department and treat the problems. You improve the quality of life. You don't need trachea. The trachea, unfortunately, the tracheotomy is always a mistake because, you know, generally many of these boys get tracheostomy because they didn't find people expert in treating their inability to cough. I have, well, I would, all my patients, they have nasal ventilations. I have only 2 patients with the tracheostomy, but the tracheostomy was made, one because he had a surgery when he was adult, and unfortunately the surgeon said that we have to make a tracheostomy because we are more sure about the anesthesiology problem. So he got a tracheostomy for that. Another one because he had so bad also bulbar involvement, also if it was Duchenne, and nasal ventilation, he's older to be Duchenne. Nasal ventilation was not more enough to ventilate him. So, but practically all of my patients, they have no tracheotomy. Also because you think about also expensive. If you make a trach tube, then you will need, as I said before here, 12 tracheostomy tubes, 300 probes of aspirations, liters of injector solution. You need a lot of money every year. While if you have a patient with non-invasive ventilation, you will spend much less money also for the health system. So at the end, what I can tell you about this is that if you have an untrained patient, an untrained family, then when you get problems with lungs, you go to the emergency room. In this case, what we do generally is they intubate him. And at the end, it's very easy to make tracheostomy. But if you have a trained patient, if you have a trained family, then they start to do physiotherapy. They use a cuff assist machine and at home. And really, this is true. It's very unusual that they go to the hospital. So it's very important to teach the family all these steps, because if they know very well to use a saturimeter and the cuff assist machine and respiratory physiotherapy, they don't need to go to the hospital. At the end, I take just 5 minutes to speak about scoliosis. This is very important because, you know, we don't do any more surgery for scoliosis since many years, and because you know, surgery is very bad. You need 5 hours of surgery. You need transfusions, and can become very dangerous for a boy with Duchenne to have surgery. So. I have to say the truth that we don't do any more scoliosis. So this is not a child with Duchenne. This is a spinal muscular atrophy, but we don't want to see any more people with such severe scoliosis. This is an Italian, but it's very important because in these slides, what you can see, this is musky means man. When you are 10 years of age, practically 80% of the length of the trunk is formed. So what does it mean? It means that if a boy walks until 10 years of age, 80% of his back will be done. So it means that the problem, the fact that he will develop a very bad scoliosis will be much less probable. If you let Duchenne walk until 12, then you will have 84% of the length of the trunk that is already made. So older they stop walking, less they will have problems with scoliosis. And in Duchenne, you can have a different kind of scoliosis. And sometimes this is all the picture. You have also hypercyphosis, that is also some Duchenne, but this is really historical because the last 10 years we didn't get any more such kind of problems. Or you can have also hyperlordosis in Duchenne. And hyperlordosis in Duchenne comes because they sit in a bad position. Actually, today with a new wheelchair that have the possibility to have the basculation of the trunk, this problem is not more present. And when you have such very bad hyperlordosis, also the lungs doesn't ventilate very well, especially the lowest part. The scoliosis, if you don't act, can be, so the progression can be also sometimes very, very fast. What we do for the scoliosis? We use orthotic treatment. We use standing, as we said before, the surgery. We say that generally the surgery we don't do anymore. The orthotic treatment, it's very important because you can slow the progression, and you can also help the sitting position. Sometimes I'm sure that other colleagues will not be, they will not agree, and they will say, the corset doesn't help to slow down the scoliosis. This is correct in a certain way, but if you put a corset when they stop walking and when they have no scoliosis, when the curve is very, very light, then you will have a very good results. If you put the corset, orthopedic corset, when already the scoliosis is there, when probably he has 70 degrees of scoliosis, then in that case, you will not have success. But if you put a corset immediately when they stop walking, and let them to have it 1 hour, 2 hours a day when they sit, in that case, the results will be very good. And not only using the corset when they sit, you cannot put corset when the Duchenne walk, but you can put it when they stop walking. As I said before, it is very important to keep that standing, because we know very well from the natural history that the scoliosis will develop immediately when they will sit. When they start sitting, when they stop walking, then the scoliosis will grow very quickly, because they will have bad positions, prolonged bad position during the day, and this will favorite the scoliosis. Of course, if you let sitting a child with Duchenne at 7 years old, and the risk to get very bad scoliosis will be much, much bigger. At the end, just 2 slides. I took these slides from a recent paper, but just to show you that there is hope, and we have several kind of targets to work with therapy, and some of these drugs are on phase 3, so are already in trials on human. You see, there are a lot of molecules, and you have a lot of the targets, because when you think of Duchenne patients, you see you have a lot of targets. You can work on fibrosis, you work on regenerations, you can work on ischemia, so you can work on necrosis. We have different targets. What I can say, this is my experience, unfortunately, until today, all the innovative drugs didn't give good results, or at least didn't give what we were expecting from innovative drugs. I feel that very important in the future will be the cellular therapy, because when you lose a tissue, a drug never make a regeneration. The drug can work on the gene, probably can make this the muscle make again dystrophy. But if you have a drug, you should start when the boy is 2 or 3 years old. But when the boy stop walking, or when the boy sit when they are 12, 13, they already lose a lot of muscles, and the drug doesn't make any regeneration. So I think the future will be cellular therapy plus drugs. They should work together, and I'm sure we will have good results. But until now, the cellular therapy had a very bad working, because there is not much interest in it. Everyone is working on drugs. But for these boys, for these kids, I hope that this mentality will change, and that all the possible way that should be taken to improve their life. And I finished 1 hour, and I thank you. Grazie.